Thank you so much for having me, and thanks also to the participants for joining. Today we are going to discuss challenges and future, hopefully, of CLL treatment. So let's see if I can switch from one slide to the other. Okay, great. Some housekeeping information. Please mute yourself for the duration of the webinar and ensure that all mobile devices are silenced. We encourage you to submit questions or comments using the chat box, but also the Q&A box that is available in the Zoom app. So any questions, I would be happy to address it at the end of my presentation. The objectives of our webinar today are to discuss the challenges associated with the CLL treatment, define what are the main factors to be taken into account in clinical decision-making on treatment with BTK inhibitors, and in order to define the eligibility of patients with CLL for different agents, and to explore future directions of CLL treatment and how they can hopefully improve the outcomes of our patients. So let's start by discussing together the novel targeted agents that have become available in the last decades. I dare say most of them are targeting the BCR pathway, and in particular the category most frequently used is including BTK inhibitors, and we have covalent and non-covalent BTK inhibitors we will discuss in more details during the webinar. But so far, the most widely available are ibrutinib, acalabrutinib, and zanubrutinib. And on the other side, we have agents targeting apoptosis, and in particular BCL2 inhibitors, and the only approved drug so far is venetoclax. In the next future, and as of today, hopefully, the majority of patients with chronic lymphocytic leukemia will be eligible for a chemo-free regimen starting from frontline treatment. And here you see that the treatment algorithm of patients receiving chemotherapy-free, chemoimmunotherapy-free first-line treatment are mainly depending on the type of treatment that is chosen. On the left, you see that patients receiving venetoclax plus obinutuzumab in frontline, they can be retreated in some countries with venetoclax-based regimen if they progress after therapy completion and either say a reasonable time frame. Progression on therapy or the rare occurrence of intolerance can lead to switching treatment to BTK inhibitors. While on the other side, on the right, you see that if the patient is starting treatment with a BTK inhibitor-based regimen, at the time of progression, these regimens are mainly used as continuous treatment. So at the time of progression, patients should receive a venetoclax-based regimen, in most cases the combination of venetoclax plus rituximab, while if the patient becomes intolerant to BTK inhibitors, we can choose an alternate BTK inhibitors or switch him to venetoclax plus rituximab. This very, let's say, dichotomic scenario has been recently challenged by the availability in some countries of the combination of ibrutinib plus venetoclax for the treatment of first line. But let's start by discussing how we are choosing first-line treatment. Of course, on the other side, you have on one side you have the efficacy data, and we have long-term data even in a high-risk patient about the efficacy of BTK inhibitors in terms of progression-free survival and overall survival. But on the other side, we should also take into account the adverse event profile, and that with continuous treatment, the duration of adverse event may be related with the duration of therapy. So this should be taken into account in order to define the best treatment regimen. You have already seen in the previous seminar very promising, very effective results in terms of efficacy of BTK inhibitors, of covalent BTK inhibitors. So the focus of this second webinar is more on how to manage some potential toxicities because some adverse events occurring in patients receiving BTK inhibitors are common, including arthralgia, hypertension, bleeding events, atrial fibrillation, and they may have a different frequency based on the type of drug, because as you see, actually, ibrutinib, the first-in-class BTK inhibitor, is inhibiting not only BTK, but also other similar kinases. And it is thought that the inhibition of other kinases may be related with some adverse event, including, for example, the occurrence of rash that is more frequent with ibrutinib due to the presence of EGFR inhibition or the co-inhibition of TEC that may be relevant in case of bleeding events. Some adverse events are actually common for the sort of class effect. So here you see that there is a proportion of patients who is developing cytopenias. Probably these are more relevant in the relapse refractory setting because patients have been previously exposed to other treatments. They are definitely less frequent in first line. We know that infections are a potential risk in patients with chronic lymphocytic leukemia, regardless of the type of treatment, but in particular at the time of treatment initiation. And we know that BTK inhibitors may impair platelet functions, and this effect is more pronounced with ibrutinib, while, for example, acalabrutinib in particular was found to be associated with a lower risk of adverse events. Lymphocytosis, I won't consider it as an adverse event, so we should only be aware that there is a redistribution lymphocytosis at the time of treatment initiation. So the lymphocyte count is increasing in the first day or weeks, and then is progressively dropping down. And this is not associated with disease progression, but it's just a sign that the patient is taking the drug, actually. Other adverse events, including gastrointestinal adverse event, musculoskeletal adverse event, rash, fatigue, headache, are less frequent and have a different profile according to the type of drug. But as a hematologist, we were well aware on how to manage cytopenias, but in the last few years we have learned more on how to manage patients with cardiovascular toxicities and other potential adverse events associated with this new class of drugs. I'm starting with the cardiac monitoring because I think this is generally a very relevant point with BTK inhibitors. So what we are doing here in San Raffaele is we are performing a full workup before starting treatment. And this is not done because we want to exclude some patients from BTK inhibitor treatment, but just because we want to identify potential comorbidities and to manage them at best before starting treatment. So here you see an algorithm where it's advised, and this is something we are generally doing, to perform an ECG before starting treatment and then every 3 months. Of course, we assess at each visit if the patient is presenting potential symptoms, palpitations, loss of consciousness, any other potential symptoms associated with cardiac arrhythmias. Generally, especially in elderly patients with cardiovascular comorbidities, we perform at baseline an echocardiogram that could also be repeated over time in order to understand if the cardiac function is worsening during BTKI treatment. And as you see, there are some cardiovascular effects associated with BTKI inhibitors that require frequent monitoring and a serial follow-up. Some of them are developing early, meaning that, for example, we do expect that especially hypertension, atrial fibrillation, or ventricular arrhythmias are developing within the first 1 year of treatment, but there is the risk that they are occurring even later. Other can occur later during treatment course, and in particular the summary of medical product characteristics of ibrutinib has been updated quite recently in order to include the risk of heart failure that, as you see, can occur within 3 years from starting treatment. So hypertension, I'd say it's quite easy to manage because we have plenty of antihypertensive drugs that can be optimized, associated in order to improve blood pressure control, but this shouldn't be overlooked. I mean, we should check for the blood pressure values, and if they persist high, we should refer the patient to the cardiologist in order to optimize the antihypertensive treatment. There is the option to reduce the dose of the BTK inhibitor, but I'd say, at least in my clinical practice, it was rarely required if we optimize antihypertensive treatment. Another potentially frequent cardiovascular adverse event is the occurrence of atrial fibrillation. The atrial fibrillation per se may be symptomatic, but many patients may also develop the arrhythmia without any associated symptoms. Again, it's worth recognizing it because especially this arrhythmia is associated with a stroke risk, so we have to identify it in order to administer appropriate anticoagulation treatment using direct oral anticoagulant instead of warfarin or warfarin derivatives. The diagnosis require, of course, the ECG. We can then discuss with the cardiologist the best management. Generally here in our clinic, we at least try once to restore the sinus rhythm. That is something that can be done in different ways, and then if the patient develops a permanent atrial fibrillation, there are drugs that can be administered in order to control, to achieve rate control so that the patient is not symptomatic. As mentioned, especially with ibrutinib, because we have actually less information with second-generation covalent BTK inhibitors, there was a post-marketing surveillance reporting the occurrence of ventricular arrhythmias. Luckily enough, this is a very rare complication, so in our patient cohort, I was lucky enough that none of my patients experienced these adverse events that, of course, can be fatal. If the patient is complaining about palpitation, shortness of breath, if we are diagnosing heart failure or other signs or symptoms associated with cardiovascular diseases, we should, of course, proceed with ECG, Holter monitoring, echocardiogram, or even cardiac MRI in order to better define the issue, the underlying issue, and try to control it at best. Last but not least, as mentioned, especially with ibrutinib, there was an update of the summary of medical product characteristic in order to highlight the risk of heart failure. There are some quite clear signs of heart failure, generally detectable by physical exam, the edema, the weight gain, the patient is complaining about exercise intolerance, orthopnea. So we have to assess the status of the heart function, and either say beside this, the ECG, in this case, also the echocardiogram is crucial in order to achieve the diagnosis, and then we can definitely optimize the concomitant medication in order to improve the cardiac function. And my focus was actually on cardiovascular toxicity, because we know that they are relevant, they are quite frequent, and they might be more challenging to manage compared to cytopenias or other, let's say, more frequent in the hematological setting adverse event. The second type of adverse events I want to discuss with you is the occurrence of arthralgias and myalgias. This has been documented first with ibrutinib treatment. It might be a class effect because it's reported also with second generation covalent BTK inhibitor. Here you see that there are some factors associated with the higher risk of developing arthralgias, meaning that younger age, female gender, frontline treatment, and history of autoimmune diseases are associated with a higher risk of developing these complications, and they actually occur earlier in patients receiving ibrutinib treatment frontline compared to relapse refractory setting. They are generally manageable, I'd say, at least in my experience. They are rarely grade 3 or higher, and they rarely affect the activities of daily living. But if this happens, meaning that even if they are grade 1 or 2, but they are limiting the everyday clinical, the everyday activity of our patients, we should consider to stop the drug for a few days and then restart at a lower dose. And generally with this strategy, we can achieve control of these symptoms and continue treatment with BTK inhibitors. And now we know that if we started treatment with ibrutinib and the patient is experiencing an adverse event that is bothersome, that is affecting the quality of life, or that is potentially dangerous in the long term, we can safely reduce the dose of ibrutinib and continue treatment at a reduced dose without compromising the efficacy of the drug. And in the meta-analysis of the RESONATE-2 trial, where they compared the patients who received a dose reduction of ibrutinib and those who continue without dose reduction, so at full dose, the estimated 7-year progression-free survival was not different between the two groups, as well as the overall survival. So this is very reassuring in terms of patients requiring dose reduction. This is not compromising the efficacy in the long-term disease control. So I'd say I'm generally starting with the full dose, and only if the patients develop adverse event, I'm considering, according to the label, to reduce the dose in order to make the treatment more tolerable. The other option we have in these days, if patients are truly intolerant to ibrutinib, is to switch treatment to second-generation covalent BTK inhibitors. And you see that in terms of inhibition of some kinases, actually acalabrutinib and zanubrutinib are more selective. So there is a much higher concentration of acalabrutinib and zanubrutinib required in order to inhibit other kinases. So the same is shown on the right, where you see the kinase selectivity profile, and you see, for example, that acalabrutinib is very specific for BTK inhibition, so while ibrutinib has less clean, let's say, profile in terms of inhibition. And there were randomized clinical trial with both drugs, so both acalabrutinib and zanubrutinib compared to ibrutinib, showing a reduced rate of adverse events. Here I'm showing you the results of the Elevator-R trial, where patients with relapsed refractory high-risk CLL were randomized 1-to-1 to ibrutinib or acalabrutinib treatment. And you see that there is a lower frequency of bleeding with acalabrutinib in red, hypertension, atrial fibrillation. These were all statistically significant. And generally a lower proportion of patients receiving acalabrutinib discontinue treatment due to the occurrence of adverse events compared to ibrutinib. And this was also demonstrated in clinical trials where ibrutinib intolerant patients were enrolled. This is the ibrutinib intolerant cohort of the phase 1/2 study, but similar results were achieved in a phase 2 dedicated trial. So these patients discontinue ibrutinib because an ibrutinib-related adverse event, and you see that the vast majority of them, when they were switched to acalabrutinib, the adverse event did not recur, or if it recurred, the grade was definitely lower, and the response rate were still very high, 75%, with a prolonged progression-free survival. So this is definitely a potential option in order to improve the tolerability of this class of agents. Again, in terms of toxicity comparison, you see here the results of the Alpine trial, where patients with relapsed refractory CLL were randomized 1-to-1 to zanubrutinib versus ibrutinib treatment. This graph is showing adverse event of clinical interest, and you see that in particular in terms of atrial fibrillation frequency, the event occurred in only 5% of patients treated with zanubrutinib, here in red, compared to 13% of patients treated with ibrutinib in blue. This was actually the only adverse event of special interest with a statistically significant difference between the two groups. If you assess the cumulative event rate, you see that with the prolonged follow-up of more than 3 years, the occurrence of atrial fibrillation with zanubrutinib is only 5.2%, compared to 13.3% in patients receiving ibrutinib. And again, in clinical trial enrolling patients with B-cell malignancies considered intolerant to BTK, there was one cohort of patients receiving ibrutinib and another one of patients receiving acalabrutinib. And you see that, again, in almost 70% of patients, the adverse event leading to ibrutinib discontinuation did not occur when the patients were receiving zanubrutinib. So in terms of tolerability, second generation covalent BTK inhibitor may be relevant and may be a feasible choice in patients who are intolerant to ibrutinib. Just to briefly mention, because we discussed in the beginning that we have different potential options. One is based on a covalent BTK inhibitor combination, and the other one is based on venetoclax-based regimens. And here, just to touch upon the management of venetoclax-associated toxicity. So the main fear in the beginning was the development of tumor lysis syndrome, because in the phase 1/2 trials, one patient died because of TLS, and there were other 2 or 3 patients developing a clinical TLS. And clinical TLS mean acute kidney failure, cardiac arrhythmias, seizures. So it's, of course, a relevant adverse events. Then the schedule of the schedule of administration of venetoclax was changed. They added a ramp-up phase, so a progressive increase of the venetoclax dose, and if you follow the rules and progressively increase venetoclax dose, either say that the risk of developing clinical TLS is negligible, and there were only few cases of laboratory TLS that can be generally managed in the outpatient setting. The risk is proportional to the disease burden, so patients with bulky lymph node 10 centimeters or higher, or enlarged lymph node 5 centimeters or higher, and lymphocytosis are at higher risk of developing TLS, and so we should, of course, introduce all mitigation strategies we can apply in order to reduce the risk. A drug like allopurinol in order to reduce the uric acid levels. For patients with low risk, oral hydration is enough. For patients with higher risk, we should consider IV hydration. In terms of the bulking strategies, I have to say that I'm not a big fan of the bulking strategy. I don't think that it's useful to add the chemotherapy before starting venetoclax-based regimen. While if we are prescribing the combination of ibrutinib plus venetoclax in first line that is approved in some countries, it's true that the first 3 months of ibrutinib single agent, the so-called ibrutinib lead-in, are indeed reducing the disease burden, and in the vast majority of cases, the patients are actually reaching low or intermediate TLS risk. So this is making the venetoclax ramp up and administration much easier. On the other side, I'd say that actually the most frequent adverse event is not the occurrence, likely enough, of TLS, but is the detection of neutropenia, that in the vast majority of cases is only a laboratory abnormality, so it's not leading to an increased infections rate. But still it might require venetoclax dose reduction, or at least the administration of growth factor support in order to improve the neutrophil count. And here you see that if we stick to the monitoring that is required per label, if we adopt hydration and agents in order to reduce the uric acid, the TLS risk is actually manageable, and in patients with high risk, it depends on the countries, but in many cases, the first doses, the first 20 and 50 milligram doses may require hospitalization in order to safely administer treatment. I just want to point out that we have to test the laboratory exams before starting treatment and at different time points after starting treatment. And as soon as we identify potential laboratory abnormalities that in the vast majority of cases are actually isolated abnormalities like hyperkalemia alone, hyperphosphoремia alone, so we can intervene and administer treatment and take care of them before they become a clinically relevant issue. Here just some guidelines on how to manage neutropenia, and in particular grade 3 neutropenia associated with infection or fever, or grade 4 hematologic toxicity. So at first occurrence, we can interrupt the venetoclax treatment and then restart at the same dose once the toxicity is resolved. I dare say that generally I first try the administration of growth factor support, and in the vast majority of cases, the neutrophil count is increasing above 1,000 per microliter. That is, let's say, our safe threshold in order to proceed with the treatment. In some cases, if neutropenia is occurring 2 or 3 times, it might require the dose reduction of venetoclax, but again, it's generally an adverse event that can be managed with appropriate support. So in the second part of my talk, this is just to sum up some key factors to be taken into account when we decide treatment for patients with chronic lymphocytic leukemia. I want to discuss with you what are the upcoming practice-changing development in the field of chronic lymphocytic leukemia. So, ibrutinib and in general covalent BTK inhibitor radically changed the management of patients with chronic lymphocytic leukemia. We achieved a great improvement with BTK inhibitors and BCL2 inhibitors in long-term disease control. But again, chronic lymphocytic leukemia remains not. We cannot cure chronic lymphocytic leukemia. So over time, there is the risk of disease progression. And here you see the analysis of the initial trials where ibrutinib in particular was administered in heavily pretreated patients, 4, 5, 6 line of treatment, in many cases, actually in the vast majority, including chemotherapy. So very aggressive diseases, and there is, of course, the risk that disease relapses over time. Generally, early progression may be associated with transformation. You see here the curve in yellow. So patients may develop diffuse large B-cell lymphoma associated with CLL, and this is, of course, very difficult to manage and a potentially dismal outcome. But over time, there is an increasing proportion of patients who is developing a CLL progression on BTK inhibitor continuous treatment. Why does this happen? We know that in a relevant proportion of cases, there is a mutation in BTK, and in the majority of cases of patients treated with ibrutinib, that was the first in class, so we gather more information for this drug. In many cases, the mutation is involving the cysteine residue 481. And this residue is crucial for the covalent binding of ibrutinib that is associated with persistent, irreversible inhibition of BTK. If this cysteine residue is not present in the ATP binding pocket anymore, ibrutinib cannot bind effectively, so the binding is actually a non-covalent binding and in the short-lived inhibition. And this was seen in a preclinical model where you see that if you compare the activity of non-mutant BTK to the normal kinase activity, you see that even at very low concentration of ibrutinib, there is a very effective inhibition of the non-mutant BTK. In light blue, while in orange, mutant BTK, even if exposed at high concentration of ibrutinib, show some activity, and in many cases is very close to the kinase activity without exposure to ibrutinib, so the original kinase activity. So as mentioned, in the initial patients who develop progression on ibrutinib, we tried to understand where the mechanism associated with the occurrence of resistance, and in a relevant proportion of cases, we identified the presence of BTK mutations. And or mutation in PRC-gamma2 that is downstream to BTK and is usually associated with activating mutations. So it's somehow bypassing the need of BTK activation because these are gain-of-function mutations in PRC-gamma2. And this was confirmed also recently by our group, where within a collaborative initiative of the European Research Initiative of CLL, we collected samples from patients followed at different sites all over the world, basically. And at the time of relapse, we analyzed through targeted sequencing the presence of mutations in BTK and or PRC gamma 2. And where we weren't able to identify the presence of the mutation, we used even a more specific technique, including digital droplet PCR. So in the end, we were able to confirm the presence of the mutations in BTK and or PRC gamma 2 in 65% of cases, but in 35% of them, we were not able to identify the presence of these mutations. So there should be other potential mechanism explain the occurrence of resistance. By the way, we identify the presence of the mutation in a low proportion of patients who were tested at the time of response on ibrutinib, and actually only few of them progressed during the observation. So it's still not entirely clear how to use in clinical practice the information associated with the detection of the resistance of the mutation in BTK. Studies from NIH confirmed that indeed the presence of BTK and PRC gamma 2 mutation can be identified months before full-blown disease progression. So nowadays it's not advised to test over time for the occurrence of this mutation because we cannot predict how long it takes to develop full-blown clinical progression once we detect the presence of this mutation. In a recent analysis, testing the presence of the mutation in patients in response to ibrutinib, they were actually able to demonstrate that the mutation is rarely occurring in first line and is generally present only in the relapse, most frequently present in the relapse refractory setting. So here you see that covalent BTK inhibitors have different structures and different key residues for binding. The C481 is in common with the ibrutinib, acalabrutinib, and zanubrutinib, but other residues may be of relevance with acalabrutinib and zanubrutinib compared to ibrutinib. And in fact, some mutations could be identified more frequently in patients receiving acalabrutinib or zanubrutinib. The C481, as you see here, is in common with ibrutinib, acalabrutinib, and zanubrutinib, but then patients receiving zanubrutinib have also frequently developed these 528 mutations, and patients receiving acalabrutinib, this 474 mutation. As you can see here, all mutations are actually clustering in the kinase domain. So the hypothesis is that these mutations are affecting not only the BTK function, but also the conformation of BTK, and that other agents, including in particular non-covalent BTK inhibitors that were recently developed, may be effective even in patients who are carrying this mutation, and they may act also changing the conformation of BTK and hampering the BTK scaffold function. And from a clinical standpoint, this was proven by the results of the Bruin study that was a phase 1/2 trial where they enrolled patients with different lymphoproliferative disorder, a large cohort of patients with chronic lymphocytic leukemia in a relevant number of cases previously exposed to covalent BTK inhibitors, in the vast majority ibrutinib. And here you see that this population was actually enriched of patients with unfavorable disease features, almost 40% carrying mutated BTK, almost 50% carrying a TP53 aberration, 85% with unmutated immunoglobulin genes, and more than 40% with complex karyotype. And 3 out of 4 patients who discontinue prior BTK inhibitor treatment did so because of progressive disease. This waterfall plot is very impressive, meaning that they achieved with the pirtobrutinib treatment a very high overall response rate, more than 80% in the cohort of patients previously exposed to covalent BTK inhibitors, and more or less the same also in so-called double exposed patients, so patients who received covalent BTK inhibitors and BCL2 inhibitors. As expected, the vast majority of cases achieved a partial response. The duration of progression-free survival in this cohort of heavily pretreated patients was around 19.6 months. And in the whole cohort, if we focus on patients previously exposed to both BTK and BCL2 inhibitors with a median number of prior lines of therapy of 5, they achieved a median PFS of 16.8 months. On the other side, of course, we are interested on the efficacy, but the data derived from pirtobrutinib cohort confirmed also a very favorable tolerability profile. And here you see that only a very small proportion of patients, 2.6%, discontinued treatment with pirtobrutinib in the whole cohort, so more than 770 patients because of treatment-related adverse events. So the drug is generally well tolerated, and it seems in terms of cardiovascular toxicity to be less frequently associated with cardiovascular adverse events compared to covalent BTK inhibitor. Unfortunately, some patients progressed on pirtobrutinib, and thanks to the analysis performed on these progressive cases, we identified that the treatment with pirtobrutinib was selecting specific clones with BTK mutation that are not the standard C481 mutation, but are involving other residue in the kinase catalytic domain. In vitro, these mutations were proved to confer resistance in a cell line model of mantle cell lymphoma to many covalent and non-covalent BTK inhibitors. Here you see that the wild type was effectively inhibited by covalent and non-covalent BTK inhibitors, but then the different mutations were associated with resistance to the different type of drugs. And indeed, some of these mutations are actually not associated with an improved function of the BTK, so they are not kinase proficient mutation like C481 mutation, but they are impairing the function of BTK. And you see here that, for example, the 428 mutation in green is actually leading to a reduced kinase activity, but still the presence of this mutation is probably supporting the scaffold function of BTK and leading to activation of other signaling pathway. In the next future, and they are currently under development, one potential strategy would be to degrade BTK, so not to inhibit the drug, but to completely destroy the enzyme within the cells. And these are the preliminary results of the Nurix BTK degrader and X2127. That was able to reduce the BTK concentration even in the presence of mutations. Last but not least, there are clinical clinical data with another non-covalent BTK inhibitor called nemtabrutinib. Here you see the design of the Bellway 01 study that was recently published, where patients previously exposed to covalent BTK inhibitor were enrolled. One cohort including patients with C481S mutation, another cohort including patients without this mutation. And here you see that, as expected, these patients were enriched with unfavorable disease features. And the progression-free survival with the use of nemtabrutinib was actually reaching 26.3 months in the whole cohort. No statistically significant difference between cohort A and cohort B, and no statistically significant difference based on the presence or absence of the C481S mutations or the presence of immunoglobulin gene mutation status or TP53 aberration. And also in terms of overall response rate, no specific category of patients proved to be less responsive, let's say, to nemtabrutinib, that was able to achieve an overall response rate around 60% of overall response rate in the whole cohort. And in terms of tolerability, treatment with nemtabrutinib was generally well tolerated, with adverse event related to the drug and present in more than 5% of instances being represented by dysgeusia and reduced neutrophil count, decreased neutrophil count, so neutropenia, with less frequent cardiovascular adverse events, only hypertension already present in the cohort under study. And with that, I hope I concluded in time. And of course, it was quite fast, so I'm happy to take any questions if you have any issue you want to further discuss. Thank you.
Thank you so much, Lydia. You were actually perfect on time, so thank you so much. Anna, do we have any questions?
We actually have some questions, yes, related to the last part of your talk. Professor Scarfò, thank you very much. So this first question is related actually to pirtobrutinib specifically. And the question is, in what treatment order and setting would you use pirtobrutinib based on the latest data?
That's a great question, actually, because at the last ASH meeting, they presented the 30 months follow-up where there was a different further analysis based also on patients who were previously exposed to BCL2 inhibitor or were BCL2 inhibitor naive. I dare say so far we have data that pirtobrutinib is effective after covalent BTK inhibitors, so we can consider either to continue the inhibition of the same pathway after the covalent BTK inhibitor failure, or to consider the non-covalent BTK inhibitor only after the patients have failed also venetoclax. So I dare say they are both a reasonable option. We have probably longer follow-up and more solid data for BCL2 inhibitor after failure of covalent BTK inhibitors, but we will gather more information in the future. So I dare say generally I would use pirtobrutinib in the relapse refractory setting in patients previously exposed to covalent BTK inhibitors. Probably in the next future, we will get results of clinical trial where we can identify a potential use of pirtobrutinib at earlier lines of treatment, but so far I would say on the safe side and use it based on the data we have currently available.
Thank you, Professor. I think that was very clear. We have a couple more questions related to adverse events specifically. One of them is, Are there any notable differences in the adverse event profiles of BTK inhibitors when used as monotherapy versus when used in combination with other agents, such as anti-CD20 antibodies or venetoclax?
So thank you. That's a great question. I dare say that the data we have so far are not showing an increased risk of cardiovascular adverse events when BTK inhibitors are combined with anti-CD20 monoclonal antibodies, meaning that from the clinical trials, we have some patients experiencing cardiovascular adverse events, but there are no signs of increased risk because the drugs are associated. They behave as expected in patients receiving covalent BTK inhibitors. I dare say the same apply to ibrutinib plus venetoclax combination, for which we have the most solid data that led to the approval and reimbursement of this combination, at least in Europe. It seems that for some adverse event like diarrhea and neutropenia, probably the combination of ibrutinib and venetoclax is somehow increasing the risk of this combined adverse event, while for cardiovascular adverse events, the frequency of these events is mainly what is expected with ibrutinib therapy. Of course, we are waiting also for the results of second-generation covalent BTK inhibitors combined with venetoclax, because there are studies currently ongoing combining acalabrutinib with venetoclax or zanubrutinib with venetoclax in first line. But I say that the cardiovascular adverse event profile is mainly associated with the BTK inhibitors, so it's not actually increased with the association of venetoclax or anti-CD20 monoclonal antibodies.
Thank you, doctor. Following with this adverse events question, we have one more. I think it's very related to the last part of your talk, which is, would you prioritize adverse events over mutational profile when facing treatment decision making?
Again, thank you. That is a very relevant question. I dare say that based on the most recent guidelines, the biomarker profile is the most relevant factor in order to decide what treatment options we have available. Of course, we have patients like those without TP53 aberration and with mutated immunoglobulin genes that have a very favorable clinical course. They rarely require treatment, and when they require treatment, they are generally responding very well to treatment. So we have plenty of options with these patients. But in my clinical reasoning, the first step is to define if there is a TP53 aberration, and then if there is if immunoglobulin genes are mutated or non-mutated, and this is basically providing the main framework in order to decide the treatment option. And then I adapt based mainly on the comorbidity and the concomitant medications, but it does say, thanks to the research achievements in the last few years, biology first, and then we tailor treatment based on comorbidities, concomitant medication, and so on.
Thank you. I think we have time for one more final question, which is actually very related to that one. The question is, what other mutations then, aside from TP53 deletions, should be assessed in a treatment-naive patient as part of pre-treatment screening?
That's a great question. In treatment-naive patients, I dare say what we should do, according to the guidelines, is to test presence of 17p deletion, generally done by FISH, presence of TP53 mutation, and nowadays I dare say probably by NGS instead of Sanger, that was the other technique, and immunoglobulin gene mutation status. There are other potentially relevant mutations, but so far they are not affecting our treatment choice, because we cannot say we will prefer treatment with one of the potential agent based, for example, on the presence of NOTCH1 mutation or SF3B1 mutation or BRIC3 mutation. So this is something that is in some instances done for research purposes, but I just say that in clinical practice has limited relevance. And the other potentially promising marker is complex karyotype, but again, is not entirely clear the number of aberrations that define complex karyotype. Eric has done some work in order to prove that 5 or more is the threshold. This was confirmed also based on the data from the CLL-13, the Gaia trial. But even if we get the information, it's not entirely clear then how to act based on these results. So I dare say we need still some work on it in order to understand how to use this information. So far in clinical practice, frontline treatment, TP53, both FISH and NGS for mutations, and immunoglobulin gene mutation status. That's all.